Diabetes mellitus is not one disease. It is a spectrum. For decades, most people believed diabetes came in only two forms, type 1 and type 2. But hidden beneath these familiar categories lies a group of rare, inherited conditions that behave differently, present differently, and require a completely different approach to diagnosis and treatment. Mody is a monogenic form of diabetes, caused by a single gene mutation and passed down in families in an autosomal dominant pattern. This means that, if a parent carries the mutation, each child has a 50% chance of inheriting it. Although Mody represents only 1 to 5% of all diabetes cases, it is often misdiagnosed as type 1 or type 2, leading to years of unnecessary insulin therapy or inappropriate management. What unites the Mody family is a shared pattern, early onset. Usually, before age 25, non-obese patients with no features of insulin resistance, preserved beta cell function, negative autoimmune markers, and a strong family history of diabetes across generations. But within this group, each subtype has its own personality, its own symptoms, investigations, and treatment strategies. In this video, we will meet realistic patient scenarios representing the most common types of MOD. For each one, we will walk through history, taking symptoms and physical findings, key diagnostic clues, confirmatory genetic testing, and the treatment options that truly make a difference. By the end of this journey, you will understand not only what Mody is, but how to recognize it, diagnose it, and manage it with confidence. Let's begin our exploration of the hidden world of monogenic diabetes.
Hi Dave, welcome. I understand your blood sugar was a bit high during your sports club checkup. How are you feeling about that?
Honestly, I feel fine. I didn't expect anything to be wrong.
Have you noticed increased thirst, frequent urination, fatigue, or weight changes?
No, none. I feel normal.
Any past medical issues or medications?
No, I've always been healthy.
Does anyone in your family have diabetes?
Yes. My dad has diabetes, and so did my grandfather. Both were diagnosed young.
You're lean and active. Any autoimmune diseases in the family?
No.
The doctor performs a focused exam. Lean body habitués. No signs of insulin resistance. No acanthosis nigricans. Normal vitals.
Everything looks normal on your exam. Dave, your case is interesting. You're young, lean, have no symptoms, and you have a strong family history of diabetes across generations. This pattern makes me think of a specific inherited type of diabetes called Mody, especially MOD3.
So it's not type 1 or type 2.
Exactly. But we need tests to confirm. I'll request the following tests to understand your situation clearly. Fasting glucose, HbA1c, C-peptide, autoimmune markers, glutamic acid decarboxylase antibodies, 65, islet antigen 2 antibodies, and zinc-in transporter 8 antibodies, liver and kidney function tests, oral glucose tolerance test, OGTT, lipid profile, genetic testing for HNF1A mutation. Once we have the results, we'll know exactly what type of diabetes you have. If it is MOD3, the good news is that it responds very well to specific oral medications.
That's reassuring. I'm ready to do the tests.
Welcome back, Dave. I've reviewed all your test results, and now we have a clear picture of what's going on.
Okay, I've been waiting for this.
Let's go through them one by one. Your fasting glucose and HbA1c are elevated, showing persistent hyperglycemia. Your C-peptide level is normal, meaning your pancreas is still producing insulin.
So it's not type 1.
Exactly. And your autoimmune markers are all negative. That rules out autoimmune diabetes.
That's good news.
Your liver and kidney function tests are normal, which is excellent. Your OGTT showed an exaggerated rise in glucose, a classic clue for Mody 3. Your lipid profile is slightly abnormal, so we'll monitor that.
And the genetic test?
Yes, the most important part. Your HNF1A genetic test came back positive. This confirms the diagnosis of Mody 3.
So it's definite?
Yes. And the good news is that Mody 3 responds extremely well to low-dose sulfonylureas. Most patients achieve excellent glucose control with very small doses.
So no insulin?
Not at this stage. With medication, lifestyle adjustments, and regular follow-up, you can live completely normally. We'll start treatment today and review your response in a few weeks.
Thank you, doctor. I finally understand what's happening.
You're welcome, Dave. Now that we know the exact cause, we can treat it effectively.
Dave is a healthy 20-year-old who discovered unexpected hyperglycemia during a routine medical check before joining a sports club. He had no symptoms, no insulin resistance, and maintained a lean physique. What immediately stood out was his family history. Both his father and grandfather developed diabetes at a young age and were managed for years without insulin. Because Dave is young, lean, asymptomatic, and has a clear autosomal dominant pattern in his family, his presentation didn't match type 1 or type 2 diabetes. His doctor ordered autoimmune markers, C-peptide, and genetic testing. At his follow-up visit, the results confirmed the suspicion. Mody 3 caused by an HNF1A mutation. With this diagnosis, Dave began a personalized treatment plan centered on sulfonylureas, along with lifestyle guidance.
Good morning, Nina. I understand your family physician referred you because of some concerns about your blood sugar, especially since you're planning for pregnancy. Tell me in your own words, what brought you here today?
Yes, doctor. My father and older sister both have high fasting blood sugar. Not very high, but always a bit above normal. I recently checked mine, and it was also slightly elevated. My doctor said it might be something genetic, so she sent me here before I try to get pregnant.
You did the right thing by coming. Mildly elevated fasting glucose, especially with a family history, can sometimes point to a specific inherited condition. Before we go further, I'd like to ask a few questions. Have you ever had symptoms like excessive thirst, frequent urination, weight loss, or fatigue?
No, none at all. I feel completely normal.
Any weight changes? Do you exercise regularly?
My weight is stable. I walk daily.
You mentioned your father and sister. Do you know their fasting glucose levels?
Usually, between 110 and 130 mg/dl. They don't take medications.
And you're planning to conceive soon?
Yes, hopefully within the next few months.
Thank you, Nina. Based on your story, one possibility is a genetic condition called Mody type 2, caused by a change in the glucokinase gene. People with this condition have mild, stable fasting hyperglycemia since childhood, and they usually don't need treatment. In Mody 2, fasting glucose is usually in the diabetic range, but the 2-hour value is often below 200 milligram deciliter, which fits your family pattern. If your tests match this pattern, we'll confirm with a genetic test. Nina, the good news is that if this is Mody 2, it's a very gentle form of diabetes. Let's complete your tests, and once we have the results, we'll plan the safest approach for your future pregnancy. Welcome back, Nina. I have all your test results, including the genetic test. How have you been since our last visit?
I've been fine, doctor. Just a little nervous about the results.
That's completely normal. Let's go through everything together.
Let's review Nina's test results together. Her fasting blood glucose has been mildly elevated since childhood, a stable pattern rather than progressive diabetes. The HbA1c is slightly above normal but steady, confirming this isn't the typical type 1 or type 2 course. The 2-hour postprandial glucose remains below 200 milligrams DAL, perfectly fitting the Mody 2 profile. C-peptide levels are normal, showing her pancreas is producing insulin properly. All autoimmune markers are negative, ruling out autoimmune diabetes, such as type 1 or LADA. Finally, the genetic test confirms a heterozygous mutation in the glucokinase gene, GCK, the hallmark of Mody 2. Altogether, these findings explain Nina's lifelong mild hyperglycemia and confirm the diagnosis of Mody 2.
Nina, this is actually very good news. Mody 2 is a mild, stable, non-progressive form of hyperglycemia. People with this condition usually live completely normal lives without medication.
In Mody 2, management is simple and reassuring. Focus on healthy lifestyle, balanced diet, and regular exercise. No medication is needed. Insulin and tablets don't help. Just annual monitoring of glucose and HbA1c for stability. Provide education to ease concerns and explain the benign nature. Offer family screening to identify carriers early. And give psychological support, reassure, reduce anxiety, and build confidence. Mody 2 cares about living well, not worrying.
Now, the most important part is how this affects pregnancy. If the fetus inherits the GCK mutation, the baby has the same glucose threshold as you. Your glucose will feel normal to the fetus. No insulin is needed. If the fetus does not inherit the mutation, your glucose will feel high to the fetus. This can stimulate fetal insulin, leading to macrosomia. In this case, we treat you with insulin during pregnancy to protect the baby.
How do we know whether insulin treatment is needed during pregnancy or not?
We decide based on ultrasound growth monitoring. If fetal growth is normal, that means the fetus has likely inherited the mutation, therefore no insulin. If fetal growth accelerates, it is likely that the fetus did not inherit the mutation, therefore we have to start insulin.
Thank you for helping me understand my condition. And now that I know what I'm dealing with, I feel so much of my anxiety has finally eased.
Each type of Mody arises from a distinct gene mutation affecting pancreatic beta cell function. Mody 2 involves a glucokinase mutation, leading to impaired glucose sensing and mild, stable hyperglycemia. Mody 3 and Mody 1 result from transcription factor mutations, HNF1A and HNF4A, that reduce insulin secretion and cause progressive hyperglycemia. Mody 5, linked to HNF1B, affects both pancreatic and renal development, producing diabetes with structural abnormalities. Less common types, such as Mody 7 and Mody 11, also involve transcription factors that disrupt B-cell regulation. Overall, most Mody forms stem from transcription factor mutations, except Mody 2, which uniquely affects glucose sensing. Through glucokinase. Mody 3 is the most common type, making up about 30 to 50% of all cases. Mody 2 follows at 20 to 30%. Mody 1 accounts for roughly 5 to 10%, while Mody 5 represents only 1 to 5%. All remaining Mody types each occur in less than 1% of cases. Together, Mody 2 and Mody 3 form nearly 70 to 80% of all Mody diagnoses. There is some variation between the clinical features of the major Mody types. Mody 2 presents with mild, stable fasting hyperglycemia, and patients are often asymptomatic. Mody 3 shows progressive hyperglycemia, and glycosuria can appear even at normal glucose levels. Mody 1 has a similar pattern to Mody 3, but with slightly milder onset. Mody 5 is distinct, combining diabetes with renal cysts, genital tract anomalies, and pancreatic hypoplasia. Across all types, common features include onset before 25 years, autosomal dominant inheritance, non-obese phenotype. Mody 2 usually requires no medication. Lifestyle measures are enough, and treatment is only needed during pregnancy. Mody 3 is highly sensitive to sulfonylurias, which are usually effective, and insulin is rarely required. Mody 1 also responds to sulfonylurias, though some patients may need insulin later in life. Mody 5 often needs early insulin therapy and careful management of associated renal disease. Other Mody types follow a gene-specific approach, depending on the underlying mutation. Mody 2 has an excellent prognosis, with stable glucose levels and virtually no long-term complications. Mody 3 generally does well with treatment, but poor control increases the risk of microvascular complications. Mody 1 follows a similar pattern, with long-term risks if hyperglycemia remains untreated. Mody 5 has the most complex course, as prognosis depends heavily on associated renal and pancreatic abnormalities, and diabetes often progresses. Other Mody types show variable outcomes depending on the specific gene mutation and accompanying conditions.